Good day, my name is Samantha Stifler. I'm from the Plastic and Reconstructive Surgery Department here at Johns Hopkins, and this is my colleague.
I'm Ray Buckley. I'm another one of the plastic surgery physician assistants. You'll see potentially Samantha and I in a lot of your preoperative consultations as well as your postoperative visits.
We're going to walk you through your breast reconstruction options today. So the first thing we wanted to start out with is you make an informed decision. There is a recent study that found about 70% of women having mastectomy were not actually referred to a plastic surgeon to determine their options as far as breast reconstruction. And so that is where we come into play. It's important to note at Johns Hopkins we have many multidisciplinary teams who offer skin-sparing mastectomy, nipple-sparing mastectomy, as well as oncoplastic or lumpectomy surgeries as well.
Throughout this video, we'll talk about who are good reconstruction candidates, what your reconstruction options are, where you should pursue your breast reconstruction, when it's best to have your surgeries timed, and why even undergo breast reconstruction at all.
The first W of those 5 W's is the who. So who can have breast reconstruction? And all women can have breast reconstruction who are undergoing mastectomy. Speak with your medical team to see if you're a good candidate. And just remember that everyone has unique goals and values, and so the options can vary. Why undergo breast reconstruction? We are fortunate in this day and age to work with a wonderful team of surgeons who can help restore your form and function, renew your self-confidence and comfort, and eliminate the need for an external breast prosthesis. A prosthesis is just a temporary type of implant that sometimes you can wear in a shirt or a brassiere of sorts, and so we can eliminate that need for you.
While we wish that all facilities offered this collaborative multidisciplinary approach to breast reconstruction, we know that that's not the case. So if you're not able to come to us for your breast reconstruction, we ask that you seek out a facility with board certified or board eligible plastic surgeons. We'll take you through kind of the basics now of what your options are for breast reconstruction. This is kind of the meat and potatoes of this video. Next, we'll talk about when each of these surgeries is done. We have 2 different paths we can go down, breast preservation or mastectomy. At the time of your lumpectomy, your plastic surgeon is involved immediately and will perform an oncoplastic reduction for you. If you're choosing mastectomy, your reconstruction options can be timed variably. First, some patients, although not many, are eligible for immediate breast reconstruction. This is not offered to many people, but it is a consideration. Most often, what we're choosing to do is place tissue expanders, do a staged reconstruction after your mastectomy. For some patients, they're not healthy enough to undergo, or the timing is just not right to undergo reconstruction at the time of mastectomy, and so we choose a delayed reconstruction. You still have all reconstructive options present to you if that's your choice.
This chart here nicely outlines the advantages and disadvantages of immediate, staged, and delayed reconstruction. This is given to you in paper form or email form upon your initial consultation with your plastic and reconstructive team. We'll touch on a few of the key components of both immediate, staged, and delayed reconstruction moving forward here. So some of the advantages to immediate reconstruction are possibly less surgery. So at the time of mastectomy, you have an implant placed, or alternatively, you have your own tissue transferred, most commonly from the abdomen. Again, an advantage may be that you have an overall shorter timeline of reconstruction as well.
While this might sound appealing, having your surgery or reconstruction performed immediately, there are quite a few complications associated with immediate breast reconstruction. Namely, the compromise in blood flow to that mastectomy skin flap that's left behind. We want that skin to be very, very healthy, have great integrity, because it's the breast envelope that's going to house your future reconstruction. Something important to consider if this is presented as an option to you is if you're willing to accept the risks that could potentially come and potentially delay other treatments such as chemotherapy or radiation if you weren't healing as quickly as we may hope.
In this section, we'll talk about staged reconstruction. One of the major advantages is that you have more time to consider your reconstructive options. At the time of mastectomy, a temporary tissue expander is placed above the muscle, and then at a later date, that tissue expander is removed and replaced either with a permanent implant or your own tissue. During that time in between, that tissue expander is expanded in clinic under a sterile procedure, and you undergo your chemotherapy and/or radiation treatments if needed.
While we talk through the disadvantages of staged reconstruction using the tissue expander, most commonly we hear patients say they don't like the idea of needing to sign up for more than one surgery. Complications also, just as they were associated with immediate reconstruction, are associated with staged reconstruction and the placement of tissue expanders. Namely, those complications are fluid collection, you may hear referred to as seroma, and infection.
Moving on to delayed reconstruction. The big advantage here is that, again, you have more time to consider your reconstructive options, and it doesn't interfere with any cancer treatments.
Just as with doing reconstruction in stages, many patients don't love, again, the idea of signing up for more than one surgery, but it can be a very responsible choice for you. Now we'll talk about what your options are for reconstruction. We'll start off by talking about breast preservation surgery, sometimes called lumpectomy, and in our plastic surgery world, you'll hear us talk through the idea of an oncoplastic reduction. An oncoplastic reduction is just as a breast reduction would be, but with the need to take out the unhealthy tissue by your surgical oncologist. The breast reduction is inherent to the lumpectomy done by your surgical oncology team, and the breast reduction, sometimes breast lift, is the role that your plastic surgeon will play. You have an incision that goes around the areola, pigmented part of the nipple, down the front of the breast, and in many women, underneath the breast fold as well. This is a really nice option if you really value breast preservation and maintaining as much healthy you as you can. We also talk about what happens when all your breast tissue is removed during mastectomy. We have a few different options. The first being is that at the time of mastectomy, as we talked before with delayed reconstruction, you may choose not to undergo reconstruction. And we think it's important to share that with you because it doesn't limit your options moving forward. You can always come back and discuss with our team what those options would be at a time of your choosing. But usually when you come to see us, you are wanting to pursue reconstruction. So then we talk about a few different avenues. One being implant-based reconstruction, one being autologous reconstruction or reconstruction using your own tissue, or a combination of the two.
So here we're going to talk about restoring your volume after mastectomy. So the first step, like we said in commonly staged reconstruction, is having a temporary tissue expander placed above the muscle before exchange for an implant and or your own tissue. This picture here is a picture of a tissue expander, again a temporary implant that we expand in clinic during a sterile procedure. The tissue expanders placed above the muscle allow for better range of motion, less narcotic medication potentially. They are filled again in clinic during this sterile procedure with a port and a needle. However, most women are numb at this time, and so they don't have much discomfort with the expansions in clinic. The expansion process is typically done on a weekly basis and on average takes anywhere from 4 to 6 weeks to be completely expanded if you have no complications during that time.
So what happens when we take the tissue expander out? Part of that comes from a discussion between your surgeon and your own preferences. I'll talk a little bit about replacing the tissue expander with an implant. Again, this will be housed above the chest muscle and below the breast skin that's left behind after mastectomy in that pre-pectoral placement. The tissue expander will be removed through the exact incision in which it was placed, and we will replace the volume of the tissue expander, a temporary breast prosthesis, with a permanent breast prosthesis or a permanent implant. It can be filled either with saline or silicone. It's important for you to know that here at Johns Hopkins, our surgeons have made a deliberate choice to only place implants, regardless of their filling, that have a smooth outer shell.
Now we'll talk again a little bit more in depth about where we can take the tissue from. Again, restoring your volume after mastectomy, you can have tissue transfer from your own body. Those options include tissue from the back, the thigh, the buttock, and most commonly the abdomen or the belly. Again, we refer to this as the deep flap, typically, DIEP, meaning deep inferior epigastric perforator. You have an umbilical or belly button incision and a tummy tuck hip-to-hip incision. That tissue is taken from the abdomen and transferred to the chest wall to reconstruct your breast.
We know this is a lot of information and it's a big consideration deciding whether to choose implants or your own tissue. Sam and I will talk through with you a few of the points that we think are important for you to take away from this video with regards to implant-based reconstruction and autologous reconstruction, or reconstruction using your own tissue. Implants are a really great option for patients who have not had or will not need radiation. Radiated skin does not love foreign bodies underneath it, and sometimes that can steer us more towards autologous reconstruction.
Conversely, history of radiation may tip the scale towards you using your own tissue and breast reconstruction instead.
Sometimes you don't have enough tissue to give, and that kind of tips the scale back my way to implant-based reconstruction. And we choose to use implants because you don't have enough of your own fatty tissue to restore the breast volume you desire.
Now, you may be a good candidate for using autologous tissue or flap tissue transfer, your own tissue, if you're healthy enough to undergo a long surgery. Some of these procedures take anywhere from 6 to 10 hours to do, and so you just need to be healthy enough to undergo such a surgical procedure like that.
Going along with what Sam just said, you may choose to pursue implant-based reconstruction if you want to sign up for shorter surgeries with fewer scars. But we know that it might require future surgeries depending on whether or not the implants need replacement in the future. In order for us to check and ensure that your implants do not need replacing and that there's not any issues that we need to address, the implants do have a little bit more maintenance associated with them. Meaning, if you have silicone implants placed, we ask that you have an MRI performed at 3 years after implantation and every other year after that to assess the integrity of the outer shell of that silicone implant. If you have a saline implant that also leaks, that would warrant reason to go back and have a second surgery or a future surgery.
Again, it is a longer surgery. You do have more scars, and we are very cognizant of where we place those scars to be aesthetically pleasing for you. It's a bigger recovery, so you're looking somewhere in the time frame of 6 to 8 weeks of activity restrictions following surgery, including a 3-night stay in the hospital. We're very well equipped with our team, both inpatient and outpatient, to handle this surgical recovery process as best as we can for you.
Either choice that you make, we think it's important for you to understand that it's very likely you will elect to have more procedures done to tailor and revise your breast reconstruction. This leads us into another question that is frequently asked of us. How many surgeries will I need? National average for reconstructive procedures is about 3 procedures. This may look like mastectomy with tissue expanders, exchange of expander for an implant, and future fat grafting. If you are choosing to use your own tissue, you may find that you have a little excess in the area that we took the tissue from, and you want to revise and contour that down more. It's important for you to know that all of these future surgeries tend to be much better tolerated in terms of the post-operative course. They will be all outpatient. You get to go home the same day, but they are worth considering in terms of your final overall goals.
It's important to talk about how your other treatments will impact your surgical timeline, specifically radiation. With radiation, we will expand your tissue expander in clinic, and you will undergo radiation with a tissue expander in. We may have to deflate a contralateral side if necessary, and your provider can walk you through this. After radiation, if you do have a deflated tissue expander, it can be rapidly expanded. And then generally you're waiting somewhere in the time frame of 4 to 6 months in order to go back for an exchange for an implant or your own tissue. Again, with chemotherapy, we can do tissue expansions, but we just ask that you have some additional blood lab workup to make sure that you're healthy to undergo the sterile procedures in office, including tissue expansion. After chemotherapy is completed, it will depend on your surgeon's preference, but generally we like to go back to the operating room no sooner than 4 weeks for reconstruction after completion of chemo.
We've touched on it a little bit throughout our discussion so far, but it's important for us to share with you potential complications that we encounter during the reconstruction process. Namely, in the setting of the tissue expander, we worry about fluid collection or seroma that resides around the tissue expander and underneath the breast skin, as it can serve as a good source of food for bacteria to want to feed on, leading to our other complication we worry about, infection. We keep close track of you throughout the process. We have a well-tailored regimen of medications to ensure that when it's appropriate that we are taking steps to ensure that the infections don't present, but it can happen. We have many tricks up our sleeves, such as oral antibiotics, IV antibiotics, but if for whatever reason you do encounter an infection during your process, I want you to know that it's very likely we will take out the expander, let the breast pocket rest for a little while, and then go back and resume your reconstruction. I tell most of my patients that they are going to have a complication, but it's important to know it's not going to impact your long-term reconstruction, just a little bump in the road. So then everyone asks, how can I promote healing? This is kind of a loaded question. We don't have a firm answer. We don't have a magic wand, but generally we want you to be healthy around the time of your surgery. If you're a smoker, we ask you to stop smoking as soon as possible. We prefer to have no tobacco on board, but no tobacco or nicotine products for 6 weeks before surgery and throughout the expansion process. If you're a diabetic, we ask you to maintain really tight control of your blood sugars, as this can really impact healing as well. Generally, we want you eating a healthy, well-balanced diet, staying well hydrated, and engaging in activities that promote mental as well as physical wellness.
One of the big questions we get asked is what you can expect your reconstructed breast to look and feel like. In terms of feeling, most women are generally numb. They do not have feeling. We do a procedure here called neurotization, where we hook up some nerves in hopes of helping you to regenerate those sensations and that feeling. But again, you can expect the breast to feel generally numb. As far as the look of it, as my colleague likes to always say, Mother Nature does it best. It will never be your native breast or your original breast that you were born with. However, our team works as diligently as we can to look at your goals and what you're comfortable with in the long term as far as your breast reconstruction. And we want you to get to a point where you are satisfied with your breast reconstruction. So what about nipple reconstruction? We here offer nipple reconstruction for those patients undergoing skin-sparing mastectomy where the nipple cannot be spared. We offer different techniques depending on the surgeon, using your own tissue rearrangement. We also offer nipple tattooing. Typically this is done through a third party that we refer to. You can have nipple prosthetics as well, which are a temporary type of stick-on nipple in order to give the effect of a nipple reconstruction without actually undergoing a procedure.
Once we get to the end of your reconstructive journey, you might be wondering what happens next. Well, hopefully you get to be rid of us for a little while, but we just like to remind you that if you have silicone implants placed, it does require some maintenance with MRIs, and we also want to make sure that you're remaining actively engaged with your oncology team. For some patients, that is annual surveillance or annual exams with their primary care. For some patients, they're maintaining an active discussion with their surgical oncologist or medical oncologist.
Finally, we'd just like to point out that we have some more information about the tissue expansion procedures and post-op drain care and post-op visits. Please refer to those extra slides and videos for further information.